All right, our next speaker is Dr. Exedy, and this is a new for these presentations. We actually have a clinical trial to talk about. And with that, I turn it over to Dr. Exedy.
Thanks, David. Can you guys see the screen?
Screen's great and your audio is great.
Wonderful. Okay. So first of all, I just want to thank the organizers of the conference for including us. It's really a privilege to be able to talk about IK930, which is our selective TEAD inhibitor. So 930 is a small molecule inhibitor, and we're developing this for treating patients who have cancers that harbor mutations within the Hipposignal transduction pathway, including patients with EHE. So, our interest in initially targeting the T transcription factors really stemmed from two important facts. The first is the Hippo pathway is commonly mutated in human cancers. About 10% of all human cancers have a mutation in this pathway. And therefore, this really represents a significant patient population with a very meaningful unmet need that can be addressed with improved therapeutics. And then secondly, there's been a significant amount of information that's come out of the public domain, probably for the last 10 or so years, really highlighting the fact that this pathway confers important compensatory survival signals upon inhibition of other targeted or chemotherapies. So we think there's a great opportunity to combine TEAD inhibitors with other therapies to overcome different mechanisms of resistance. So what I'd like to do today is spend a little time just giving some background, reiterating probably what was spoken about earlier today around the Hippo pathway, the T transcription factors, their relevance to EHE patients, and then talk about 930 specifically. I'm going to share a little bit of the preclinical data we've generated around this molecule. And then lastly, I'd like to spend a little bit of time talking about our early clinical development strategy for this program, which does include specific cohorts of patients with EHE. So just to start off, on the left side of this slide highlights the Hipposignal transduction pathway. And so this pathway is activated by multiple extracellular as well as intracellular cues. And it comprises a kinase cascade, starting with NF2, which can activate two kinases, MST1 and 2, along with their partner SAB1, which they themselves can activate two other kinases, LATS1 and 2, and with its partner MOB1, can phosphorylate these two key transcriptional activators that we've spoken about today, one being YAP1, the other being TAZ. And upon phosphorylation, YAP1 and TAZ are basically sequestered to the cytoplasm by various chaperone proteins. They can be then ubiquitinated and then subsequently degraded by the proteasome. And so through either normal regulation or through mutation in the upstream portion of this pathway, YAP1 and TAZ can translocate to the nucleus, they can bind to the T transcription factors, and they can help mediate expression of a number of genes associated with tumor initiation, proliferation, metastases, therapeutic resistance, etc. And there are a number of nodes in this pathway that are commonly mutated. So for example, NF2 and LATS1 and 2 themselves can actually undergo inactivating mutations, and therefore these are considered tumor suppressors. And then YAP1 and TAZ are commonly either amplified, overexpressed, or can undergo genetic fusions, and therefore YAP1 and TAZ are considered to be oncogenes. Now, there are certain indications that have high incidence of mutations within the Hipposignal transduction pathway. And so I'd like to highlight some of those on the following slide. Now, importantly, I mentioned that about 10% of human cancers have mutations in the pathway. And this actually comprises about 125,000 newly diagnosed patients within the United States on an annual basis. And some of these indications with high incidence of Hippo pathway mutation are shown on the right. For example, if we start in the middle, so malignant mesothelioma, the Hippo pathway is the most commonly mutated signal transduction pathway in this disease. Somewhere between about 40 to 50% of these patients have mutations in NF2 itself. And these mutations are associated with poor outcome in patients, really regardless of the therapeutic intervention. And then there were a number of other kind of more rare cancers that have high frequency of NFT mutation. And these include meningioma, cholangioma, glioma, schwannoma, and a few others. There are also some high incidence solid cancers that have significant amount of genetic aberration in this pathway. So for example, in non-small cell lung cancer, about 6% of the patients have amplification of YAP1, and about 30% of them have amplification of TAZ. And given the fact that this pathway is known to drive resistance to EGFR inhibitors, we think this is an important genetic aberration to look at in regards to resistance to third generation EGFR inhibitors. And then lastly, the pathway is commonly mutated in soft tissue sarcomas. So we often see YAP and or TAZ overexpression, amplification, frequent nuclear localization, and then of course, genetic fusions, including in EHE patients. So I want to spend a little bit of time kind of going over some of the information that was already shared throughout the day, speaking about the relevance of TAZ and YAP and TEAD in patients with EHE. So, the TAZ-KMT1 fusion is the most common genetic aberration in this disease, comprises the N terminus of TAZ, the C terminus of the calmodulin binding transcriptional activator 1. And what's interesting is that the strong nuclear localization sequence of KMT1, along with really the loss of these phosphodegradon sites and the C terminus of TAZ, really makes this fusion protein refractory to normal Hippo pathway regulation. And Brian Ruman earlier today discussed some of the genetics studies looking at genetically engineered mouse models, really demonstrating that this fusion protein is essential for the transformation of normal vascular endothelial cells into EHE. And what was interesting in these papers was that the fusion itself is essential for continued survival of these cancers. So removal of the TAZ-KMT1 gene basically results in tumor regressions. And importantly for our purposes, it was also demonstrated that the T transcription factors are also essential for the survival of these cancers. So this was shown in the genetically engineered mouse models, where, for example, an overexpression of a dominant negative version of T2 led to inhibition of tumor formation. And this was corroborated also in Drosophila model, as well as some of the cell culture models that Dr. Rubin presented in the video. So our hypothesis is that inhibition of the T transcription factors should overcome the TAZ-KMT1 mediated survival within EHE. And so that is why we'll be targeting IK930 for this disease. So with that, I want to take a transition now and give a little bit of background on IK930 itself. So as mentioned earlier, the T transcription factors have this central lipid pocket. And this central lipid pocket binds to the fatty acid palmitate. And this binding of palmitate to the T transcription factors is really essential for their normal interaction with YAP1 and TAZ, as well as its ability to bind to DNA and drive transcription. So IK930 was really designed to bind to the central lipid pocket, prevent palmitate from binding there, and therefore disrupt normal T function. So some of the data we have characterizing 930 as a T inhibitor is shown on this slide. So in the lower left, in that blue curve, this is just a luciferase reporter assay with T promoter elements. And you can see in this case that IK930 inhibits T-dependent transcription with an IC50 of about 20 to 25 nanomolar. In this greenish yellow line is a viability curve, and this is in an NF2 mutated mesothelioma. And again, you can see that there's an IC50 in this case of about 20 nanomolar. Now the specificity for 930 in cancers that have a mutation in the Hippo pathway is illustrated in the graph in the lower right. And so in this case, this is a viability curve in a mesothelioma cell line that does not have a mutation in the Hippo pathway. And you can see in these control cells, which is shown in blue, that 930 does not affect the viability. However, when we knock out NF2 with CRISPR, you can see we've now sensitized these cells to IK930. We also see in the upper right that 930 can actually inhibit expression of multiple T-dependent genes. And we've shown this in vitro here. We've also seen this in vivo models as well. And then lastly, the overall pharmacological properties of IK930 are favorable for human testing. We think there's essentially a low risk for any drug-drug interaction or off-target toxicity concerns, given that it's very clean in CYP panels, hERG evaluation, as well as a safety panel profiling. But we've also looked at the anti-tumor activity of IK930 and in vivo xenograft models, and that data is shared here. So the data and off to the left, this is an NF2 deficient mesothelioma grown as a xenograft in mice. And you can see in this case that relative to vehicle, treatment with IK930 once daily results in favorable anti-tumor activity. The experiment in the middle is in another mesothelioma model. This particular model has mutations in both LATS1 and LATS2. And again, you can see that IK930 results in good anti-tumor activity here. And then lastly, off to the right, this is a head and neck squamous cell carcinoma model that has YAP1 amplified. And you can see 930 leads to good anti-tumor activity in this model as well. Now, relevant to today's conference, we don't have experimental data yet with 930 in EHE models. We are, however, collaborating with a number of participants here today and others to try to understand better the activity of 930 in EHE models. And we're also generating some cell-based models internally to try to understand better the relationship between PAS-CAMT1 fusions and the T transcription factors. Now, as I mentioned, the Hippo pathway plays an important role in driving resistance to other therapies. So for example, it's been shown with targeted inhibition of EGFR, ALK, KRAS, BRAF, MEK, CDK4/6 inhibitors, others, that the Hippo pathway can become activated through a diverse set of mechanisms and essentially drive resistance to those different types of therapies. And it does so by driving expression of genes that are involved in cell cycle entry, DNA replication, and then expression of anti-apoptotic genes. So for example, in the basically it's been shown that the Hippo pathway functions in parallel with RAF and MEK inhibitors or EGFR inhibitors in driving expression of anti-apoptotic genes, thereby conferring resistance to targets of these different oncogenes. In addition, it's been shown that MEK inhibition downstream of KRAS mutation can trigger YAP1 upregulation, nuclear localization, and therefore in a KRAS context can also drive resistance to MEK inhibitors. And it was shown and discussed a little bit earlier today as well, and it's been published that the EHE genetically engineered mouse models have an activated RAS signature. So we believe that there's a strong opportunity for combining IK930 with MAP kinase pathway inhibitors, including MEK inhibitors. Now, Dr. Rubin mentioned this morning, he referred to an ASCO presentation that was presented last year, evaluating, and this was from a phase 2 study of the MEK inhibitor trametinib in patients with EHE. And although this phase 2 study did not meet its goal for the objective response rate, there was clear evidence for clinical benefit in these patients. So you can see that the overall response rate in the study was about 7%, but the majority of patients treated in this trial did have a reduction in their tumor size, and that's shown in this waterfall plot at the lower part of the slide. In addition, about 17 patients out of the 41 that were treated stayed on therapy for greater than 6 months, and 7 of the 41 remained on therapy for greater than 12 months. And there was also an improvement in the pain scores in this study as well. So although trametinib didn't meet the goal of the study, it's clearly an active agent, and therefore it may actually combine well with other therapies, potentially with TEAD inhibitors as well. Now, we haven't explored the combination of MEK inhibitors and 930 in EHE models yet. However, we've done a significant amount of work looking at MEK inhibitors combined with IK930 in KRAS mutated cancers. And I'm going to share some of that data with you now because I do think it could be relevant for future development opportunities in EHE. So the data I'm showing you on this slide is looking at the effect of 930 combined with trametinib across a number of different KRAS mutated models. And what we're looking at is we're just looking at the kinetics of apoptotic cells appearance over time in each one of these curves. So if you just focus initially on the set of data in the upper left, this is looking at the incidence of apoptosis induction in the colon cancer cell line HCT116. And if the lower part of the graph, you can see that IK930 on its own really is not increasing the incidence of apoptosis in any way above the vehicle. Trametinib as a single agent does lead to some elevated formation of apoptosis in this experiment. And interestingly, when we combine trametinib with different concentrations of IK930, we really significantly increase the incidence of apoptosis in these cells. This effect is recapitulated in a number of these other models as well, including Lovell, A549, and CALU1 KRAS mutated cells. We corroborated this beneficial anti-tumor activity that we see here in vitro, in vivo as well. And that's shown on this slide right here. So what you can see here is that this is the 3 different KRAS mutated models grown as xenograft in mice. Off to the left is an HCT116 model. And you can see that basically the combination of IK930 with trametinib leads to beneficial anti-tumor activity relative to either single agent alone. And this beneficial combination we see here, we see it also in the A549 model, as well as in the Lovell model as well. So this will be a key part of our development strategy for IK930, combinations with other targeted therapies, including MEK inhibitors. Now, I want to elaborate a little bit more on our planned development strategy for this program, but just prior to that, I want to talk about a few more studies that we did just to really help specify the indications we were most interested in pursuing in our early clinical trials. So the data shown here is looking at some data that we derived from the TCGA data set. So the graph to the in the left portion of the slide is looking at the incidence of various Hippo pathway mutations across all indications in TCGA. The chart in the middle is looking at a transcriptional YAP-TAZ activity score across these indications as well. And when we look at both of these pieces of information, there's some overlapping tumors that continue to rise. For example, mesothelioma, head and neck cancer, cholangiocarcinoma, non-small cell lung cancer, and others. We've also developed immunohistochemistry assays so that we can look at YAP1 and TAZ expression in tumors, but also specifically their localization to the nucleus, which would be indicative of pathway activation. And we have used that to help also inform indication selection. And with this approach, we see high expression of YAP and TAZ in the nucleus in a couple of indications where there is significant pathway mutation, including meningioma, multiple sarcomas, mesothelioma, cholangiocarcinoma, non-small cell lung cancer, and a few others. So based on this information that I've shared and discussed, we've basically come up with a strategy for developing IK930, exploring its ability as a monotherapy in patients with mutations in the Hippo pathway, as well as exploring combinations. So for a monotherapy, we plan to look at NF2 deficient orphan indications, and this would include mesothelioma, among others. And then we'll also want to treat patients that have YAP and or TAZ genetic fusions, and in particular, EHE. We're also going to be exploring multiple combinations with IK930. So we want to look at KRAS mutated cancers in combination with MEK inhibitors. We're interested in looking at EGFR mutant cancers in combination with 3rd generation EGFR inhibitors. And as the data evolves in the clinic, as well as what we can continue to do non-clinically, we'll explore additional combinations beyond these as well. So just lastly, just want to talk about our phase 1 design for this program. So the IND for IK930 was approved by the FDA late last year, and we're hoping to initiate the phase 1 portion any day now. So we will have a standard dose escalation for this study. We will be looking to enrich for patients that are known to have high incidence of mutations in the Hippo pathway. And then we'll expand into, as a monotherapy, into 4 separate cohorts. So we'll be looking at NF2 deficient mesothelioma. We'll also have a cohort of patients that's somewhat tumor agnostic, but with other, but also including NF2 mutations. We will have a cohort dedicated to patients with EHE. These patients will have had evidence for TAS-CAMTA1 or YAP-TFE3 fusions by either RNA-seq, FISH, or immunohistochemistry. And then lastly, the final cohort will be a tumor agnostic cohort where we'll be looking for other indications with YAP1 and or TAS fusions. And so with that, again, I really want to just extend our appreciation for allowing us to be able to discuss IK930 to this group. We're super impressed with everything that this group has done over the years. And lastly, just happy to take any questions.
Excellent. Thank you so much for the presentation. And we have a few minutes for a Q&A session here. We've got a couple questions that have come in. The first question, does IK930 bind all 4 TEADs with the same affinity?
Yeah, that's a great question. I mean, we do know that, the TEAD inhibitors bind with differential activity to the TEAD inhibitors. We have a number of studies ongoing right now, biochemical assays, cellular assays, to really confirm what the general general potency across the different TEAD inhibitors is. It's a little difficult to kind of get a full answer on this, mainly because it's very context dependent. But so these studies are ongoing right now.
And what kind of toxicity are you seeing with IK930?
Yeah, so I mean, in humans, obviously, we're just at the precipice of starting our first in human dosing. In preclinical models, I would say that the Hippo pathway, there's been a number of studies looking at YAP knockouts. There's been other kind of publications with experimental TEAD inhibitors that show that the primary toxicity organ with this mechanism is the kidney. So we do believe that that YAP and TAS, as well as TEAD, have an important role in kidney podocytes. And so we think that's probably the biggest, that's the organ where I think we'll see the most serious toxicity if we do in humans. But I would say that we had a very favorable toxicity profile with 930 in our GLP enabling toxicity studies.
We just got another question that came in. This one might be hard to answer, but at least we can estimate. How quickly can we get this trial to patients?
Yeah, so I mean, our estimation is that, again, if we can start our dose escalation portion of the study soon, we would anticipate, a standard timeline to get through the dose escalation, depending on, the type of adverse events we see and the challenges with any enrollment. But, our objective is to hopefully enroll through the dose escalation portion within about 12 months or less. And at that point in time, we'll initiate our expansion cohorts. And again, as I mentioned, we will have a dedicated expansion cohort for EHE. And I would say that during the dose escalation, we will once we reach exposures of IK930, where we think we're in the biologically active range, we are allowing for backfill cohorts as we continue to dose escalate, where we'll be including or enriching specific patient populations of interest within, for example, the 4 cohorts I mentioned. So EHE patients will be of specific interest during that dose escalation backfill cohort.
And have you done structural analysis of the TEAD with and without the drug? And specifically, is there anything you can comment on about any potential allosteric rearrangement or the impact of the drugs in the pocket on the structure of the TEAD?
Yeah, no, that's a great question. We haven't looked to see, at least from us, we do have crystal structures, co-crystal structures with T2 and, IK930. So we have an idea of how it binds within the central lipid pocket. But we haven't, I mean, these are with the part of, these are portions of the T protein. It's not the full T protein, so we don't know exactly how it would affect its interaction with the YAP and TAZ. I think somebody else mentioned earlier today that it's very difficult to develop soluble full T transcription factor.
Excellent. And that's all of the questions from the audience. Thank you again so much for your time today.
Thank you.
For the group, we are now going to transition to a roundtable session, and everyone needs to know that that's actually a separate session you need to join to access the roundtable. And we'll see you there.